Welcome back, everybody. Okay, so for our next session, it's going to be on simplifying minimally invasive mitral valve surgery. And Dr. Mettauer is going to start us off. We've got an exceptional team panel with us. Of course, to the left of Dr. Mettauer is Stephanie Ibus, and she is a perfusionist extraordinaire who's become an expert at the art of systemic hyperkalemia and removing the potassium. To my right, of course, Minh Tran. He's the male version of the perfusion extraordinaire. There's a female version and a male version. And Clint Robertson, my old friend from Alexandria, Louisiana, who I've known now for about 12 years.
I think so.
12 years.
That's crazy.
Yeah. He used to be young and good looking, but now, that's my job.
I'm starting to look like Joe.
Do you have hairy ears?
I don't know.
I think you're growing some hair on there. Okay, so we're going to get moving. I think Dr. Mettauer is going to do some narration on a procedure that we did for him here at CHI St. Luke's, the Woodlands Hospital, where he is the chief of cardiac surgery and medical director. And he's going to narrate this and talk a little bit about just minimally invasive mitral valve surgery and how that is just such I think a beautiful technique compared to the sternotomy for isolated mitral valve. Okay. Rod, you ready? Okay.
So basically, we have your ideal patient here, and we'll talk about some of the other body habitus that you can utilize with this technique. When I was approached by Joe with this several years ago, one of my colleagues that I trained with, Chance DeWitt in Louisiana, was doing some of these in some of his higher risk patients that were redo and not wanting to do a redo sternotomy. And femoral access for this is key, so that's one of the things you have to evaluate, and utilizing fem-fem bypass. But I trained with Dr. Cooley. His quote was, the KISS method, keep it simple, stupid. And I trained in more of a traditional cardiac surgery type program where sternotomies, big incisions, etc., and didn't really have any reason to try a minimally invasive approach other than the public kind of starts demanding it, and where we are in the Woodlands, which is kind of like the Beverly Hills of Texas, you start getting some pressure to do these types of things, or you end up losing the cases. However, so Joe introduced me to this technique. You can see here a little axillary thoracotomy. This is a little bit generous because it's one of my first ones, and you're basically going about the fourth intercostal space. And the reason I even considered this technique was the simplification of it, not that it was a new technique to repair or replace a mitral valve. It's well established. It was taking the load off of me as the surgeon, and very importantly the anesthesiologist, and putting all the burden really on perfusion. And they're the experts in perfusion, and this shouldn't be terrifying because the very first case that Stephanie did with me was her very first time to do it. So the learning curve is extremely steep. A couple of cases and you got it. From a perfusion standpoint, from a surgeon standpoint, the techniques are there. If you know how to do a mitral valve, you're going to love the exposure. Most importantly, from a surgeon standpoint, is the technology for access. You can see here I use S-Tech. You can use pretty much whatever minimally invasive type of retractor system. I've even used Tufiers, small finichettos here, but the main component is the atrial lift, and we'll show that in a minute. I don't use port access. We're not going to utilize an endo balloon. We're not going to put in a retrograde cerebral artery catheter, which slows everything down, because those can be difficult to place, and it also, again, puts that burden on the anesthesiologist while you're sitting there drinking coffee. And for me, I've got a full day usually, and I can't spend all day doing one case. I cover multiple hospitals, although this is my main hospital at CHI St. Luke's, the Woodlands. So you can see the phrenic nerve easily here at the bottom part of the incision. This one, I used Alexis, which is utilized by the general surgeons and robotic surgeons for hand-assisted surgery, so nothing fancy, relatively cheap device. You can go, I've even started using the smaller Alexis because it creates a lower profile, especially, believe it or not, on your larger patients. The largest patient I've done with this is about 6'5", 6'6", and was about 350 pounds, and he was big all over. And this guy had a massive chest, and that was about the limits of the instrumentation. We did have to use some of our long bariatric laparoscopic instruments to kind of help in that from the the gastric sleeve operation types from our general surgery colleagues. But it was definitely doable, and the results, even though it took about an extra hour longer, it was a repair. He did awesome, and to do it through that incision for him, it's going to be hard either way. A sternotomy in that guy is going to be difficult because Dr. Ott, David Ott down at Texas Heart always said mitral valve surgery generally is your hardest, most difficult procedure to do in the chest. And I tend to agree with that, although there's some easy ones through a sternotomy, but this way the exposure is excellent. So what we're seeing here on the TEE images is the severe regurgitation. This particular gentleman had previous mitral endocarditis, had perforated valves. We had originally planned to try to repair with core matrix and even put a ring of core matrix in to keep everything clean from a tissue standpoint because he had an acute component to this. However, when we got in there, the valve was irreparable. It was really quite disgusting. So here we are priming the femoral artery and femoral vein cannula for bypass. Obviously, key to get the air out. I don't use transcranial Doppler. We've tried to get it in. It's as a community hospital. There are costs to consider, but I think once we get to a point where this becomes more of a mainstay, that shouldn't be a problem. So this particular incision here, the bottom one, this is one I use for multiple different instruments, but most importantly during the case, using your pump sucker to retract and to give you additional suction. The drawback of this technique, because you're not cross-clamping, is that if you have more than 1+ AI, aortic insufficiency, the amount of drainage into your field is high. 1+ is a lot of drainage to almost moderate, but with this sucker and a weighted drop sucker and appropriate angle and lift on your atrial lifter, you can usually control it enough to be able to see what's going on. And for me, you can take not all day, but you are continuously perfusing the coronaries with oxygenated blood, so you have a rest because your systemic potassium is 10, 12, 13, whatever it takes to stop
18.
the heart, 18. I know it's crazy, right? But you're getting oxygenated blood to the heart. You're basically just shorting it out, but the tissues are getting perfused, and they fly off pump. I mean, it is the smoothest transition you've ever seen when Stephanie or Minh start doing their job in the back. Again, the burden is on them, and they've taken the burden off of anesthesia and the surgeon. You're not on a time limit other than a pump run. So I consider this basically like, ECMO, doing heart surgery on ECMO. And you know how long you can do VA ECMO on people. You can do it for quite some time. So here we are looking at, we're on pump. We have a nice sharp QRS interval, and we're starting to slow the heart rate down.
Yeah, I think that's the Pacers mic, and I think the GTF's good potassium.
Yeah, and once you give the potassium, you have almost immediate arrest. Okay?
Can you talk about the atrial lifter real quick?
Okay, the atrial lifter, yeah.
What happens when you don't have it? You try to hold it by hand.
Well, the first one I did, that was the only thing that the Aztec company, before they were bought, they didn't bring the atrial lifter part. So I had my partner holding a handheld lifter from the mitral set, and it was miserable. You can't, there's just no way to have somebody, well, I guess if you have the perfect assistant, you can have them hold it, but you got to have the atrial lifter. Again, you're taking this out of the hands of a person and putting it into something that's not going to move throughout the case, because you got to have the atrial lifter. That is the key. I don't care. Edwards, I think, makes one that we've used before. For me, it's this. I'm sure Dr. oh gosh, what's Miami Instruments? The guy at Texas Heart downtown now.
Dr. Lamellis?
Lamellis, he has a set that he uses. So, but they're all basically the same as far as the atrial lifter. You got to have it. Okay.
Hey, Raj, can you go back on that to that echo, that black and white image that was just about 10 seconds before this? Because I think you want to comment on that.
And I think in this
there you go.
And I think also this particular guy is like, you got to be careful putting this in so you don't hit the mammary.
Yes. Yes.
If you hit the mammary, it's a problem. But anyway, and we did, and had to fix it.
Yep.
Or clip it. But anyway, so you see the handheld sucker here. That's actually pulling down on the posterior aspect of the atrium. We're a good 2 centimeters in front of the phrenic nerve. You want to stay away from that. And there's the atrial lifter. You can see the metallic instrument in there, and it's on a post on the contralateral side of the bed. There's CO2 coming in from about 2 o'clock, and I'm using a lighted sucker by Invuity. And I use those on aortic valves, mitral valves, because I really don't like wearing a headlamp. I do wear one on a mitral. That's about the only case in a thoracotomy for lobectomy I use a headlamp. So you can see, I mean, you've got a direct shot in. The heart's perfectly still. This valve is garbage. We test it. We look at it. This isn't going to be reparable because almost all of the valve is diseased. And the annulus is calcified too. So for him, and we counseled him beforehand, the 50-50 repair versus replacement. My repair rate is about 80%. It's not 90 or 95. And I use the Dr. Lowry method, generally speaking, to repair valves. I don't cut any leaflets out if I can help it. I think you need to utilize the tissue you're given. And even though I trained at Texas Heart, I'm open to new techniques. So
Clearly.
all right. So visualization here for me is great. For the video camera, I'm trying to get out of the way a little bit. But again, I think we've made the decision to remove the valve. If there's any posterior leaflet that's normal with chordae, I leave that. And again, that's surgeon choice because, as we know, we like to leave some of the chordae intact. But again, this is a heavily diseased valve. If it's just a floppy myxomas valve, those are pretty easy to fix. Barlow's type, I think those are great actually to just repair. But again, we're sitting here chatting and talking, and you're not under that time constraint of cardioplegia being administered for me, I do it every 10 minutes. Most guys do it every 20 minutes. Back to what we talked about using retrograde perfusion, whether it's in the brain or in the heart. Does the right coronary ever get perfused with a retrograde cannula? If you have an antegrade cannula in, that's more tubes and wires. You got chipwood clamps all through this small hole, and this hole can get smaller and smaller when you don't have all of that instrumentation in there. So you saw where we removed the valve, multiple fenestrations, just a goodness awful looking thing. And here's Stephanie being attentive as usual. And we're still flat line, and I think we're about to start coming off. And did we cool this guy? We did cool him pretty good.
We're about 30.
And that does help with the amount of potassium that you give, and as far as being less. But we've given upwards of how many milliequivalents on that big guy? Was that a 600 or 800?
That was an outlier. We probably gave about 550.
Yeah. So that's what we call in Texas a Huntsville dose. And if you're from Texas, that's where we still believe in the death penalty, but it's compassionate, and that's what they give them. So that's what you're basically giving patients is an intravenous dose of high dose potassium, and with the aid of the heart-lung machine and a competent or moderately competent aortic valve, you can perfuse the heart, and you really don't get ischemia, which is the best part of this. And especially if you're on a learning curve to try to learn how to do minimally invasive, I think this would be a great way to start because it is simplified. Maybe if you wanted it to progress to something more advanced where you're doing a guy that has moderate AI and maybe look at a more normal technique where you're cross clamping or using an endo balloon or something like that, then that could be utilized as well later on. But this is for all intents and purposes, the perfusionists are your training wheels. You can be rest assured that the heart's getting perfused and you're not under the time constraints that you normally have. Now, if you can see here, there's a fair amount of perfusion, there's a fair amount of blood in the field, but this is controlled with the weighted drop sucker and that pump sucker that's retracting down. This was our kind of almost moderate AI patient. And I've been pushing the envelope with that because at the bottom of the line, end of the day, if it doesn't work out and you can't see because there's too much drainage, you can still convert to a sternotomy and you haven't had an ischemic period. So you close it up, and I have done that. In my very first case, when we didn't have an atrial lifter, I did that and the guy did fine. Not ideal, but I did tell him that that would be possible. I don't tell him now because we've gotten good at great patient selection. So the next best thing ever invented most recently, and I think most heart surgeons will agree that have used it, is the CRNAs. You got to have a 2-0 braided suture. I still use the David Ott method, which is 12 sutures for a replacement. Aortic valve, if it's 21 or less, it's 9, 3, 3, and 3. If it's 23 or higher, it's 4, 4, and 4. It works great. It's simple. It works for pretty much everybody. So here, 12 sutures. The CRNAs comes in a pack of 12, and this easily shaves off 30 minutes or more if you're using a knot pusher.
Which really hurts us a little bit
does.
because we've got to be even faster now getting that potassium out and getting rewarmed.
Well, true, but if you communicate and you guys see that I'm using that, then you know to remind me.
Yeah, except
Right,
well,
but we
no,
wanna
we
make
can't
sure the
start too
valve
early
looks
because we don't
good.
want the heart to beat.
True,
Right.
that's true. But you can, once the valve is in, especially on a replacement where you're not as concerned about a significant leak, you don't have to really worry about that. Now, on a repair, I get it. You want to be a little slower, but again, you have the benefit of being on FemFem. Regardless if the rate's slow coming off, you can wait a little bit. Especially if you're learning with this new technique, it does simplify it. You have time. You can. These guys can spin it off a lot quicker than you think. I mean, you're hurting yourself a little bit there on that because it doesn't take as long as you would think to dialyze and get this off.
It was the warming that took longer than getting the potassium off
Right.
for us.
In larger patients, you got to consider that.
Patient, yeah.
Yeah.
Which I think surprises
This guy's
a lot of
super
people.
skinny, so it's not that hard.
Right.
So now we're checking the valve. You put your weight, don't forget, now you got CO2 in there, put your weighted drop sucker through the leaflets, make sure you have plenty of slack because they're kind of sticky with the other cannulas and your suckers and you're going in and out. You want to keep that in till the atrium's closed. And I'm testing the valve with usual method there. You really don't have to, especially this guy who's got pretty good AI, just let it fill up and test it with a pickup, okay? And I've done mechanical valves. The replacements, obviously, they're even easier this way than it is with an open procedure because you can see the anterior portion of the annulus. So we're trying to get the atrial lifter out. Don't forget your pacing wires. I always forget because you're you're jazzed about getting finished. The pacing wires, that can be a little challenging putting in. I just always use ventricular wires because that's the way I was trained. You can do atrial and ventricular. Get you a good piece of epicardium to put it in and bring it out through the right upper quadrant of the abdomen or right lower portion of the chest. I usually just use one and a grounding wire because I'm a big believer also. And this is the other reason I wanted to use this technique was I believe the fewer holes you have in the heart, the less chance you have to bleed. Okay, so
makes sense.
same thing for aortic valves. I don't put a superior pulmonary vein vent in. Dr. Ott dropped one through the root, and you kind of get blind to it. It's kind of like a fire hydrant in your yard. When you buy that house, you're like, man, there's a fire hydrant in my yard, and it's an eyesore. Nobody knows there's a fire hydrant in your yard. And we just recently had a big freeze down here. Nobody notices where the water meter is. I had to go find the water meter for my sister-in-law and turn it off because she had a leak in her house.
Oh, Lord.
Yeah, but you think of all these things that that you don't, that are kind of like eyesores, but you kind of get neglectful of it. So same thing for me with the aortic root vent. So that's just a little aside. So I don't put a superior pulmonary vein vent in. I do not like it.
But getting back to that pacemaker, making sure you put it on before you fill the heart. 'Cause
Yes, 'cause
once
once
you
you-
come off,
It is very painful to put in. And it's not the end of the day if you do. You're there in the operating room, you could float a temporary if you want. Make sure you at least get an atrial, because that's easy to put in. Because you're in this particular instance, you're more likely to have bradycardia from kind of a slow atrium than you are to have heart block from hitting the bundle of His on an aortic valve replacement. So if you have an intact bundle, an atrial wire should suffice. So at least have that if you forget. I haven't done that yet, but mainly it's because Stephanie and these guys have reminded me. I think I forget about 50% of the time on the wires.
You never.
Because you're ready to get done.
You never forget anything, sir.
Right. Whatever. Not the super important parts, but I've forgotten pacing wires. Anyway, so the heart, you can see, was filled there, and now we're coming back to the monitor, and we are rewarming, and we've obviously stopped the potassium. The heart's, the LV's decompressed, although the right heart still has some water in it. You can see there's a little bit of air in there, but that's not significant. Now, on this particular one, the LV vent is slipped back once the heart filled up, so you got to put it all the way into the apex. But again, it had sucked out enough of the air to be insignificant. Oh, you got to have single lung ventilation, obviously. Anesthesia has to put in a dual lumen tube for this. Contraindications are, if you get in there and you got dense adhesions, it's your level of comfort on taking those down and looking. But there really are very few contraindications to trying this technique. It's the same ones you would utilize for what I would call a traditional, it's kind of funny saying that now, traditional minimally invasive mitral valve surgery. But this technique simplifies it to where if you have been hesitant to use it, or you feel like you have resistance from anesthesia, because it does put a large burden on them, this technique, basically they're sitting back there, in the case of one of our CRNAs, listening to YouTube videos while perfusion's doing all the work. So if you're a perfusionist,
that's how it always is, isn't it?
Drinking coffee and watching the Wall Street Journal. That's
correct.
Anesthesia mantra.
That's right.
Exactly.
Correct. All right. So at our institution, we use CRNAs that are very well trained. So if you're hesitant about that, and you can get the right CRNA, and in a lot of ways, I like them better than the anesthesiologists. No offense to anesthesiologists, but as a surgeon, you tend to have a little less of that dynamic of, it's my way, no, it's my way. So that's just a little preference of mine. And the timing of this is once you decide to come off and stop the potassium and they're rewarm, it is, see the sharp QRS complex? It's not that kind of wide, ischemic, coming off sluggish. It's pretty snappy. It's because you've not had an ischemic arrest. So this is for a skinny guy, pretty generous incision. It's one of my first ones. I use JP drains. Put one in the pericardial space, just fit it in there, and one posteriorly in the pleural space. You can see your wires coming out. We've decannulated, repaired the arteries, and getting ready to go to the ICU.
Very good. That's excellent. That is great. Did we ever find Dr. Jones? Yeah, he has to call our call-in number. Just have him call our call-in number, and it can just be on the phone, and I think we'd be okay with that. Yeah.
Just my background, I think I trained at the best place in the world, but I was a great laparoscopic surgeon, at least in my own mind. 20-minute gallbladders, 15-minute gallbladders. Heart surgery, I didn't want to do anything like this. This technique basically, I wouldn't say revolutionized my practice, because I still do a lot of open, complex stuff, but this is a nice adjunct to my practice, and it's only because of the simplification of it. Because the last thing I need is to be running anesthesia, running perfusion, worried about all these different variables, and the number of variables are decreased by at least half, I would say, by using this technique. This is it is truly so simple and so safe And I think you've even thrown it out there. You're willing to teach anybody how to do this. This isn't proprietary. I mean, this is,
No. I mean, look.
this isn't Joe Basha's technique. I mean, but
I do take a royalty. Anybody that wants to use it, I don't mind.
well, anybody can go on fem bypass and
Yeah.
give high K and then
Yeah,
dialyze it
yeah,
off. All right,
yeah.
but the point is,
potassium off that.
But
Yeah.
but from especially a community surgeon standpoint like me, or maybe even an older surgeon who's not really wanting to do this, or a younger surgeon just coming out who's by himself, this takes a lot of the burden off of the surgeon. It really does.
Well, man, how many people here on the panel have used port access?
See, I've never used it, so I can't weigh in
You've
on
never
it.
used it. Okay, so it used to be heart port, and then it became port access. And look, I mean, it was agonizing.
Painful.
I mean, you would sit there at start the case at 7 o'clock in the morning with the patient in the room, and it was 11 o'clock before they got all these lines in. I don't know if that's
right.
what y'all saw. But the same contraindications for this technique are the same contraindications that actually exist for port access. With the exception, you brought it up, I think, very eloquently, you don't have any ischemic time. There's no having to give cardioplegia. So if you have more than 1+ AI, you're not supposed to use port access. 2+ AI certainly is a contraindication. But I think with this technique and enough sucker strength,
I think that guy was pretty close to 2+.
AI.
I think we got misread.
Right, but we just had a big session on TCD and putting the valve, even if you put a wire around the arch to get down to the left ventricle on a cath, you're knocking off atheroma. There's embolic events occur. So now you're going to put this big endo balloon around the arch and inflate it, and it migrates and it moves. We're not measuring that. I think that is is a serious problem. And then what I'd like, if we could, did we get Dr. Jones on the phone? No? Okay. So while we're waiting to get Dr. Jones on the phone to kind of discuss that first case, Stephanie, do you want, I think that might be him right there. Yeah, please. Hey, Dr. Jones.
Hey, Joe, how you doing?
I'm doing great. Hey, Dr. Jones, you're here on our panel. Here is Dr. Mark Mettauer. Stephanie, he's, I think you know Dr. Mettauer from the conference.
Hey, Dr. Jones.
Yeah.
Stephanie,
How you doing, man?
Stephanie Ibus, perfusionist, Minh Tran, perfusionist, and of course you know Clint. I think he works with you on a fairly routine basis. And
Yeah.
Hey, Doc.
Dr. Mettauer just gave an excellent overview of with actual surgical video of the hyperkalemia technique for minimally invasive mitral valve surgery. And I was wondering if you would be so kind as to sort of describe that first procedure that we did when we did this technique. So the technique I did originally with Dr. Jones is the first case, and maybe talk about some of the resistance people may have had, but how it ended up essentially, your decision to try it because of the patient's anatomy, having previous surgery, and the lima on the sternum, and just talk about how that first procedure actually went.
Okay, first let me tell you, Joe, I want to congratulate you on your webinar program. Actually, I was watching you guys, waiting to get connected. I'm sitting in front of my computer, and apparently I'm on the Wi-Fi, but for some reason, it's not coming through.
That's okay. Everybody knows how good looking you are, Doc. So and you got a great voice. So we'll just put a picture. I wish I had a picture of Dr. Jones. I'd put a picture of you up if I'd have known would have had a trouble connecting. But you know what, everybody in the audience, go ahead and register for the New Orleans conference today and come visit with and meet Dr. Jones in June. So that's the best way I think to handle that. But go ahead, Doc.
Well, let me just start off by saying that this came about because at that time in our program, I was looking for a better way to do minimally invasive mitral valve work. And actually had traveled to several locations to view their procedures. And actually came back a little get befuddled because I thought there might be a better way. So when I was presented with this case, the lady who had previously underwent coronary bypass grafting, and all her grafts were open, and she needed a mitral valve procedure. I knew I didn't want to do a reduced sternotomy if at all possible. So putting together that case, and Joe, you were intimately involved in, and putting that idea together, I had seen this done, but it was done with fibrillatory arrest. And that case lasted about an hour. And although the patient did recover, the post-op was difficult. That was a case I viewed at another hospital. So I thought, why have the myocardium using that much ATP when we can arrest the heart and do the procedure and hopefully get a better outcome. So again, putting that idea into practice, we came with the idea, but let's just stop it with high dose potassium and do the procedure. Now, as you remember, there was no literature that we found that had described anything of that nature. So we were sort of like on not fertile ground, I guess you say. But knowing that this could be a better procedure for the patient, we embarked on this, what turns out to be the first case, actually that we ended up getting printed, of hyperkalemic arrest for mitral valve repair or replacement.
So, hey, Roger, do you have that article by any chance that you can throw up there? And Dr. Jones, we did find a picture of you. So, you know, getting back to that port access, you brought up a really good point because this was a redo with all patent grafts. So you got the mammary, and now you're gonna, if you're using port access, you're going to have to deal with that, and you have, because you're on pump, right? Mm-hmm. And so that's going to continuously be perfusing. And if you have patent vein grafts in the aorta, you're going to occlude them with the endoballoon. So that's
right.
Yet, or you don't think so? Or
Well, it depends on where they are, but yeah.
Yeah, possibly.
Yeah, so you could basically give retrograde the whole time.
Yes,
or
right, so you have to do the retrograde, certainly, exactly. So yeah, so that first case, so how'd that patient do?
Well, you know, actually she did extremely well. And we were very pleased with the outcome.
So there's your article.
Oh yeah.
Which led us to having that in our armamentarium when those type of patients presented.
Mm-hmm. So, you know, did you have any fear when we first did it? Were you afraid?
No. I think we had planned it out to the point that if everything had gone well technically, she would have a good outcome.
Mm-hmm.
Well, it's the same thing I discussed earlier, Dr. Jones. If it's not going to sit up right, then you can be committed to the sternotomy, and you're already on fem bypass, and it actually makes it a little, you know, as you know, a little safer to do a reduced sternotomy. I think, in my opinion, we don't always like to do that, but I'm always wired out on a redo anyway for a reduced sternotomy for fem bypass.
So let me ask the perfusionists in here. Can you guys discuss the circuit? So you're actually the first. So I got to do the procedure first with you. Now, what did you think when I told you what we were going to do?
Dr. Jones may not have been nervous, but I was a little nervous.
Okay, and Stephanie. So I got to do it first with you as well.
Stephanie's eyes were that big.
I was uncomfortable.
You were uncomfortable,
Yes.
and Min?
I didn't know what I was getting into, but I was I was ready for it, but it was a little bit.
That's what
nervous.
I was saying. Min's
Good
my
answer.
favorite, by the way, in case anybody
That's
didn't
why.
know that. So talk about the circuit. Stephanie, can you describe the perfusion circuit and how we set that up?
Well, initially, we always have a hemoconcentrator in our circuit anyway, so we had the one, and then we added another one through the roller head where we would usually do the cardioplegia.
Hey, Raj, do we have that diagram? I'm sorry to bother you. Forgive me. Go ahead, Steph.
We've had questions of, do you really need 2 hemoconcentrators? And I would say yes, so that you could get it all off in a fast amount of time. Then I also used one of our other pump heads to Y in our Duosol for continuous infusion.
Now, can you talk about Duosol, what Duosol is?
Yeah, so these are the things, a couple of the things that would make maybe if you're starting at a small community hospital, you might be uncomfortable with the things we're telling you to get. At St. Luke's, they do continuous renal replacement therapy, so they already have the Biberon. You have to have 0 potassium bicarbonate Biberon so that you can continuously infuse. We're basically Z-buffing. And people have asked also, why can't you just drop a liter, take it off, drop a liter? But you know, if we're replacing about 10 to 15 liters of fluid, it works a lot better just to have a continuous infusion. So what I noticed, the speed basically ends up being around, we're taking off about 250 mLs every minute, and that's what we're replacing with. So in 30 minutes, that's 7 liters, 7,500 mLs. So you can see in 30 minutes you can get off quite a bit with the 2 hemoconcentrators.
Now, he talked about that one of those patients where we gave a massive amount.
That was very
and that was an
unusual.
outlier.
It was an outlier.
But how much of replacement fluid or Z-buff, CVVH did you do on that patient?
I would say we were probably around 20 liters.
20 liters. And we still had a little bit of a problem post-operatively with with a little bit of rebound hyperkalemia, if I remember.
We have seen that a little bit in our patients. You're going
It's
to get
the
a
big
little
patients.
rebound. Yes.
It's the larger patients. So,
But we've been actually just giving Lasix before we leave the room, and I think that's helped a lot.
So, yeah, that's a good idea. And of course, you could do, glucose and a little
we've
bit
done
of
that.
insulin.
Right,
We've
we
done
do
that
that
as well.
also.
And you just have to remind the ICU, because they're being educated on this as well, that feel comfortable in ordering more labs, iStats, follow your potassium, and believe your potassiums. And it's not going to sneak up on you, but it's unless you draw labs for 12 hours. But it's the larger patients. We've been had not a trouble with that, but we've had a couple of that outlier. Another large lady we did, but it's part of the critical care management. Our pulmonary critical care physicians and nurses are now more comfortable with it.
Well, Clint, so you've probably done the most cases using this technique of anybody at this table. So what's your what kind of wisdom can you impart to our colleagues out there in web world about this technique?
Well, I think our circuit and our setup is basically pretty similar to what you described. I think the 2 hemoconcentrator technique is definitely the way to go. I think the first couple of cases that you and I did together, we didn't cool very far. We weren't using esmolol, and I think once we started doing that, I mean, we saw the amount of potassium that we had to give these patients, go down, dramatically. I think when we first started, we were starting with a bolus of 240, 260 milliequivalents, and I think now in our protocol, what we use back home is we start out with 180 milliequivalents and see where we're at from there.
That's
We need to give more, we give more. If we, and I'd say more times than not, we don't. But to go back on that, us cooling down to 30 degrees, 28 degrees, 25 degrees, whatever we need to do, and anesthesia given the esmolol bolus and starting an esmolol drip once we go on pump has helped out tremendously.
Minh, what's your thoughts? Now you've only done one case.
I've only
is
done
that
one,
right?
but I've watched about 4 cases.
About 4 cases. What are your thoughts? What could you tell our colleagues out there about who want to try this technique? You know, let me tell you this before you know, to kind of give you a sort of a background. Stephanie and I, we published that case online on ViewMedi, and anybody out there that is looking for a great resource for educational videos is viewmedi.com. They do a fantastic job, and there's a lot of material out there for learning about stuff that hell I'd never heard of, and it's really, really interesting. But we have gotten about 6 calls from people, 3 of them who said they really wanted to do this, but then they ultimately they didn't. And Dr. Jones, maybe you guys, you and Dr. Mettauer could weigh in on this too, but why is that? Why do they say they want to do it, but they seem to have this level of fear and they just won't do it? Because it seems like a no-brainer to me, much better technique.
I think in the perfusion community, you know, just in surgery, you know, doing a case, you know, there's always the fear of, you know, safety issues and the unknown and what people aren't really familiar with. But, you know, I think if, you know, you have the right people setting things up and kind of getting you on track on how to do the cases, what protocols to do, how to approach it from anesthesia, surgical standpoint and perfusion standpoint, and everything's laid out. I think it's a safe method to arrest the heart with no ischemia, and, you know, as long as you get the heme concentrators in to get the potassium off adequately, you know, when the patient comes off, I think, you know, it could be a great case, especially for the, you know, because you want to do minimally invasive procedure and not having to use the endoplant.
Yeah.
For me,
So,
it was.
I think,
Go ahead, Dr. Jones. Sorry.
no, go, Mark. Go ahead.
Well, for me, I don't know. I think I was particularly tired when Joe approached me with it, so I was like, sure, let's do it. But I'm not putting any brain ATP in doing this. I'm going to do the mitral, and you do everything else. Mm-hmm. And anesthesia, oh my gosh, they were like, you know, hesitant. Fortunately for me, I didn't have the perfusion pushing back because it was Joe. So I didn't have to fight that battle, but we got one of our more aggressive anesthesiologists involved who will pretty much do any case and doesn't care. And so, you know, because he put all the burden on perfusion as well. And for me, that's where I left it. And again, your fem bypass, I mean, the wheels aren't going to fall off the cart. Mm-hmm. I mean, even if you give a whole bunch, worst case scenario, you're going to let it wear off. Mm-hmm. I mean, give a bunch of Lasix or whatever. So, but the learning curve, like I said before, is, I mean, would you agree it's steep?
Absolutely.
I mean, I to be honest with you, I mean, I don't want to learn how to do it, but it doesn't seem to me like I would have to do that many cases, or at least watching, to be able to instruct somebody how to do it. You got, I mean, Stephanie did one case, was like, that was, yeah, you can do it.
This was easy.
I mean, this was easy. Yeah. I mean, it's
but
not.
Doesn't it shorten your operation too, Dr. Jones? Doesn't it make the operation itself shorter?
But it did for us. And I think that you have to have the perfect storm. And what I mean by that is, when I said I wasn't afraid when I first did this case, that wasn't the first time I had used that approach to do a mitral valve. That had been in my armamentarium for a long time.
You're talking about the right anterior thoracotomy.
Exactly. Right. I mean, the mitral valve, minimally invasive, aortic valve, minimally invasive. So it wasn't my first time doing it. It was the first time we were going to use this particular protocol to arrest the heart. Mm-hmm. So, I mean, I don't think this should be someone's first out the gate time of doing a minimally invasive mitral valve. They should try it.
Well,
also, it was great that Joe was there, and actually we had talked to Joe for a while. As far as anesthesia was concerned, they came along without any difficulty. So it was a perfect start.
Mm-hmm. Well, it was my first.
Mm-hmm.
so
that was your first.
That was the first minute. Yeah.
Anterior approach.
I'd seen George Rule do one through a big, huge right thoracotomy. Mm-hmm. but that was my first.
But you know, if the patient doesn't get a sternotomy, that is better for them. I mean, in terms of their recovery and everything else. I mean, I'd rather have it done, especially women.
Yeah.
You know, I mean, it's much.
There's a
more,
lot of benefits. I mean, you know, thoracotomy is not without problems too. I mean, you can get chronic post-thoracotomy syndrome, but yeah, I agree. I mean, it's if it's an isolated mitral valve, I don't even care about that, to be honest with you. I don't care if, you know, about if it's a sternotomy or thoracotomy. For me, it's exposure on this. I mean, it's so much easier. And I think anybody that does minimally invasive mitral valves, robotic mitrals, whatever, knows that it's easier. I mean, I don't see why this wouldn't, you know, at a robotic center that does mitrals, I don't know why that.
yeah, I don't
This
know.
this is, in my opinion, the easier way to do it, especially if you're and most of those are in residency training programs. I mean, FemFem, High K.
And there's no rush.
And no rush.
You're not
the resident
stressed.
can do it. You know,
Yeah.
you can do or get through part of it or whatever. Yeah.
So, Clint, Minh, Stephanie, one of the things that I've noticed is that when we come off pump with these patients, and Dr. Jones, Dr. Mettauer as well, but I noticed that their hearts almost appear, even if they were a little depressed to start with, hyperdynamic. What do you attribute that to?
I think it's 100% FO too,
Yeah.
to be honest with you. I mean,
Good
just,
perfusion
I
of
think
an
it's
empty heart.
temporary.
Good
I think it's
perfusion.
temporary.
It is. They
So-
tend to go back.
Yeah.
But how much of the high volume ultrafiltration do you think contributes to the removal of
And the heart's not
inflammatory
distended
mediators?
either.
That's true.
It's
too.
not swollen.
No walls. No
you don't have
stress.
this. Yeah, you can close the pericardium if you want. I usually put just a couple stitches, but it's not like after doing an open where you get that reperfusion and swelling. You don't have the swelling.
Yeah.
Well, I mean, I think it's all of that. I do, and I think 100% as well. When you're doing high volume CRT, in particular CVVH on these cases, I mean, you're removing these inflammatory mediators, systemic
You're not getting a
inflammatory
surge
responses
type
now.
response that's
Right.
out of control.
Yeah, I think it's
Absolutely.
it's a big impact, huge.
I do want to touch on
Hey, Joe, let me say, Joe, let me just-
yeah,
let me just
Dr.
say this
Jones,
too.
go ahead.
Something that's probably obvious. There's no better perfusion for the myocardium than blood.
Yeah, that's true. That's true. That's the best cardioplegia in the world with potassium in it.
The question I've been getting a lot is, what does all that potassium do to the rest of the body? Are we causing any harm? And I'll tell you, we haven't seen any issues. They're awake, extubated the next day, talking. Have you seen any?
No, the physiology of the human body is if you have systemic potassium is to get rid of it, whether it's pee it off, drive it into the cells. I mean, the ionic gradients are such that it's going to happen. You just, I think unless, you know, once you get most of it off with what you guys do, the human body takes care of the rest. It's not, it's you're resetting that and from that mechanism, the potassium, sodium, ATP,
Sodium pump and all
yeah,
that
all of
stuff.
that.
Right.
Sodium, potassium,
Well,
yeah.
you know,
So there's no
interestingly enough,
long-term
400 of potassium is barely 10% of the total body load of potassium. So it's
Right.
really not not as much as you think it is. It's just extracellular. It stops the heart. Now, two caveats to that. Don't give it fast.
That's right.
Because if you do, we've seen that
Oh, yeah.
before. You'll see a big spike in your blood pressure.
pressure,
You'll
yeah.
you'll see
Definitely.
that reaction occur. But you know, in talking to every physiologist and pharmacologist and intensive care doc that I could find, nephrologist, everybody, there is no morbidity associated with giving someone 400 potassium except cardiac arrest, diastolic arrest, which is what we're trying to achieve, unless you're in Huntsville, and then, you know, the consequences. So you need to be on bypass to do this. But going back to that solution, the pediatric folks are very, very familiar with this. So we've all, as perfusionists, we've Z-buffed in the past using normal saline. It's acetate-based, not bicarb-based, so you get the pH adjustment, but you dilute your bicarb as you constantly are doing, removing fluid and replacing it with saline. This solution is normal physiologic bicarb-based, but just take the potassium out. You get multiple formulas with calcium, without calcium, with potassium, zero potassium, 2 potassium, 3 potassium, 4 potassium, whatever it is you want. So we use zero potassium, but we can do this enormous volume of hemofiltration, Z-buffing in essence, for people who are watching this familiar term, and have the bicarb the acid-base balance just stays perfect.
I would not try to do this with just normal saline and bicarb.
I wouldn't either.
God, no.
It'd be
If
a
you're
horrible
thinking
idea.
about it, don't.
Horrible idea. So, with all of that said, Dr. Jones, any final thoughts on what we're going to do? Now, I don't know if you have the time, but if you could just hang on for a little bit. I think we want to go to a quick commercial break, and then that gives people time to call in because they may have some really good questions about this. And I think we'll put the call-in number. So if you want to call in and ask any questions of the panel that's here, and also Dr. Jones, who's remote over in Louisiana, Roger's putting the number up right now. Go ahead and call in, and the phone lines are open. And Dr. Jones, do you have a few minutes to hang around?
Sure.
That'd be great. Okay, so we're going to go to a quick commercial break. You'll still be on the line with, actually, how are we going to do that, Roger? How can he be on the line?
You can stay on the line through it all.
He can stay on the line through it all? Okay, good. So yeah, if you'll just stay on the line, you'll still be live with us, but we're going to go ahead to commercial break, and then when we come back, some people will be calling in with some questions.
Okay.
So we'll see you all back, and just watch the commercials, okay? Remember, we got to keep the lights on, and we monitor who's watching. So if you leave and try to go to the bathroom right now, I'll see you left your computer, so hurry back.